let's start with large airways. What are large airways? So basically, large airways are airways that are more than 2 millimeter in diameter. Now remember, large airway includes both your central and peripheral airway. What are your central airways? That's your trachea and your mainstem bronchi. And peripheral airways are lobar bronchi, segmental, and then subsegmental, right? So again, large airways are central and peripheral airways together, which are more than 2 millimeter in internal diameter. Now, role of imaging. What does imaging help in evaluation of the tracheobronchial tree? It will help you in detection, localization of where your lesion is, etiology, whether it's an intrinsic, extrinsic lesion, what is the length of the abnormal segment, whether there's a diffuse or a focal presentation, whether there is any obstruction, degree of narrowing, and in certain specific situations, it helps to give you specific diagnosis. Now, X-rays per se are your first modality that you do for any chest pathology. So for large airways also, we do chest X-ray. Specific conditions like foreign body, mucus plugs, a collapse, it would quickly show you. But CT remains the modality or the gold standard modality of choice for imaging of your large airways. Now we obtain multi-detector CT, which are volumetric, which give you thin sections, volumetric data, and they are done in a single breath hold. There's generally a single breath hold scan. Now, the first image that we look at from a CT scan is your axial sections that we often discuss even in our talks. The multiplanar reconstructions are to visualize the anatomical structures in reality. It also helps to show you airway stenosis. So basically, after your axial, coronal, and sagittal images, you have reprocessing, and you can, reconstruct images. There are softwares available in the packs these days, in the radiology systems these days, which help you to generate images which are specific, and they help you to identify certain pathologies. For example, your min IP images or the minimum intensity projection, which help you to identify the overall morphology of the tracheobronchial tree. So as we go ahead, we'll talk about each of these. Now look at this min IP image, which is the minimum intensity projection. So what has happened? It is showing you your tracheobronchial tree very clearly. It is clearly delineating all the segments, and it is showing you the anatomy very clearly. So any airway pathology, it can help you identify the location, it can help you identify whether it's cranial, caudal, what is the location, and where is the pathology. So min IP is in minimum intensity projection. In specific for large airways we are talking about. We're going to talk about this again as we go ahead. Then there is maximum intensity projection, which improves detection of nodules and bronchial disease. There's something known as volume rendering, which is useful in overall depiction of the airway anatomy. So look at this. Look at these images. This is basically a minimum intensity projection. And what has happened is the airway has been volume rendered and the airway has been made prominent. Now, when you look at this airway, this generally doesn't help you identify anything in specific, just gives you a better visualization, better depiction of your airway. As you can see, the larynx, the trachea, the carina, the mainstem bronchi, and the further segments as well. Now, there is something known as dynamic CT, which is also seen for your airway collapse, and there is virtual bronchoscopy. Now, virtual bronchoscopy helps you to identify, supposedly you see a lesion on the CT. You can actually look at the lesion through the virtual bronchoscopy in the specific segments or the specific areas. The difference between virtual bronchoscopy and real bronchoscopy is that you cannot take real-time samples, your bronchoalveolar lavages, and diagnose the underlying specific condition when you require BAL and other samples. However, you correlate with the CT and you can find the exact location internally within the airways where your lesion is through virtual bronchoscopy. Now, MRI, we've been talking about MRI, and it is coming up in a very significant way, even for chest and thoracic diseases, and even for central airway evaluation. It provides adequate visualization of tracheobronchial tree up to the lobar bronchi. So, in the coming times, there are times when MRI is still used and would probably be more used even for chest and thoracic diseases. So, large airway diseases can be congenital, iatrogenic, traumatic, infective, inflammatory, infiltrative, can present as extrinsic compression, neoplastic. So, let's look at the imaging of some of these. Let's begin with congenital diseases. So look at this image, and this is basically this is a min IP image, and this is your volume rendered image. So if you can see through the trachea, there is a tracheal bronchus which is coming out. So when you normally, this is an incidental finding. It wouldn't be very significant clinically, but as a physician or as an intensivist, if you work and you have to intubate a patient, and you end up putting your tube a little ahead, and if this gets obstructed, then you can cause the right upper lobe segment to get completely collapsed. So that is where this becomes a little clinical significant for us. Otherwise, it is an incidental finding. Similarly, accessory cardiac bronchus is also a incidental finding. Does not have any clinical implications, as you can see here also, that there is a bronchus which is originating. This generally originates from the bronchus intermedius, commonly seen on the right side. And as you can see, this is going towards the pericardium. So again, an incidental finding, doesn't really have much clinical implication. Now, something like bronchial atresia. Now, you would have an X-ray with the hyperlucent left upper lobe. So in this case, you might think of a pathology. Now, when you look at the CT cut from the same patient, you see that there is abrupt cutoff and there is no left upper lobe bronchus. This condition is commonly seen in the left upper lobe, and you would see that there is air trapping on the left side because of this abrupt cutoff. So this is where is bronchial atresia. So you should know about these congenital conditions. Usually in adults, they are not significant. Now, after the congenital conditions, let's look at the central airway obstruction. Now, causes of central airway obstruction can be extrinsic or intrinsic. Amongst the intrinsic, you can have your lesions from the walls, so something which is completely obstructing your intraluminal obstruction lesions. And then extrinsic, you can have various causes. So let's begin with intrinsic causes of congenital causes like tracheal stenosis. When you look at these two CT images, you can see that there is presence of tracheal stenosis there. The trachea seems completely compressed. Look at this sagittal view. You can see that there is a longitudinal tracheal compression over here. There is stenosis over here. Usually, these airway conditions are associated with surrounded, their wall thickening. But in this case, there is no significant wall thickening, which also, tells you that this could be congenital tracheal stenosis. Then again, this is a min IP image, and look at like I told you, it tells you about the bronchial anatomy, and you can appreciate tracheal stenosis here. So it can help you identify the length of the stenosis, and where exactly is the stenosis. Then, when we look at the inflammatory extrinsic conditions, inflammatory intrinsic or infective conditions, we have lymph nodes in the central airways as well. So look at the compression of the right main bronchus here with the large lymph node mass, sorry, over here. Then we have intrinsic inflammatory or infective conditions like infections like tuberculosis, there could be vasculitis, there could be relapsing polychondritis or post-intubation strictures, sarcoid, IgE4 related diseases, broncholithiasis. So let's look at the imaging of inflammatory and infective. Now remember, in tuberculosis, there are other findings in your lungs like there can be your cavitating lesions, there can be cavitations with consolidation, there can be lymph nodes. But in the airways, you would see that, like, for example, look at this. That in the left main bronchus, there is surrounding wall thickening and there is narrowing of the left main bronchus. When this was rendered on a 3D volumetric image, again, you see there is narrowing. So this is also another finding of endobronchial tuberculosis in the airways. You would see wall thickening, which is one of the main presentations in large airway diseases. Now, in sarcoid, again, when you have a clinical picture, you have a patient with specific signs and symptoms. You can have bilateral hilar shadows. You can have advanced stage with interinterlobular septal thickening. You can even have advanced stage of fibrosis in sarcoid with hilar shadows. You can also have nodular and smooth wall thickening, as is seen around the bronchus, if you can appreciate. So this is another finding, and it is also seen in up to 65% of patients of sarcoid. So this has to be clinically as well as, along with other radiological findings associated, not just the airway wall thickening or the thickening around the bronchuses. Now, this was a case of granulomatosis polyangiitis. Again, with granulomatosis polyangiitis, which was known as Wegener's granulomatosis earlier, We know that there are present of cavitations, nodular shadows, there's specific history, there's a presentation of the patient, which is also very varied and extensive. But this was another airway involvement in the patient with GPA, and you can see that subglottic there is wall thickening. If you can appreciate, there is significant wall thickening. Again, around the bronchus, there is narrowing and there is wall thickening, which is what is very pertinent to the large airways. Then we have talked about ABPA, and we've talked about the hyperattenuated mucus variant of ABPA. As you can see, this glove, this finger-like projections because of insipiciated mucus in the airways, and it is appearing like this, hyperattenuated, characteristically seen in ABPA, and it is very pathognomic of the ham variant, right? And as you can see, there is again on the lung window also, you can see this presence of the same along with some nodular shadows, often seen in patients with asthma, as certain patients of asthma. Now, relapsing polychondritis is another condition of this. And this, usually you would see that the anterior end of the airway, the trachea, has thickening along with calcification. Now, because the posterior part does not have any cartilage, there is sparing. There's nothing. You can appreciate this here also, the thickening and the calcification. Another cause is broncholiithiasis, and you would have a patient with tubercular lymphadenitis, and there would be, it would rupture into the lumen, and this is as you can see here, characteristically, a calcified nodule is, blocking the lumen. It was seen on the bronchoscopy as well. Again, a calcified nodule completely obstructing over here. So this is another presentation, broncholiithiasis. Now we've talked about the inflammatory and infective conditions. We talked about the intrinsic causes. Let's look at the extrinsic causes of central airway obstruction with masses, right? They can be lymphoma, they can be germ cell tumor, vascular malformations, and intraluminal you can have benign and malignant tumors. So we look at some CT pictures of these as well. Now look at this anterior mediastinal mass. It is completely compressing and displacing the trachea, causing extrinsic compression of the trachea. This is actually a dual aortic arch in a child, and because of this, it was causing compression of the trachea. Again, it's showing extrinsic compression. And this was a known diagnosed bronchogenic carcinoma. As you can see, a large mass here on the mediastinal window, and it is compressing the trachea as well. It's displacing. Then again on the lung window, you can see it, and this is a min IP image. And look at this. Now, when you look at this, I'm so sorry. You can see that with this mass over here, it is compressing the trachea. It is causing compression at the level of carina and even the right main bronchus. So now this is what is good about this image reconstruction. It helps you to identify the exact levels also, gives you a complete detailed anatomical detail. Now, again, infiltration with the neighboring malignancies. As you can see, this is a large thyroid mass, and it is displacing and causing even compression of the trachea. Now, bronchial hematomas, it is seen as on a lung window, it is seen as a non-specific mass lesion, but then something specific about hematoma we have discussed previously also. As you can see, there is some fat and then there's some calcification over. This black portion is actually fat and this is calcification, very specific for hematomas, right? It is characteristic of hematomas and it is causing the bronchial lumen to obstruct. Then some of the tracheal tumors, like the adenoid cystic carcinoma, as you can see, it is obstructing the lumen of the trachea over here. You can see the mass lesion also over here. And when you look at the bronchoscopic view, you can see it is completely obstructing the tracheal lumen. Now, this was a case of squamous cell carcinoma. Something specific about malignancies, which are, malignant, not benign. You would see that, there is infiltration of the trachea, like in this case of squamous cell. There is irregular wall, the lumen is narrowed, and it's also starts to infiltrate surrounding structures. Now, bronchial carcinoid, again, you can see that, there's a well-defined round shadow in the bronchus, and it's obstructing the bronchus. Now, something specific about the carcinoids are generally, diagnosed on biopsy, of course, and this would be a presentation. But when you look at the PET scan or the DOTA scan, these are very highly avid. And because of this, sometimes you're able to differentiate that possibility of carcinoid is more in a specific setting, of course. But then they are very highly avid lesions. Now, metastasis to the trachea is rare, but whenever it's there, is usually associated with the pathology. Like in this case, there's effusion and collapse of the underlying lung. If you can see that there is metastasis in the lung, there is, irregular, ill-defined lesion, which is almost obstructing the tracheal lumen, and it is infiltrating the trachea. Now, amongst various other causes of central airway obstruction, mucus plugs, we as clinicians, as physicians, would often come across. Generally, it is one of the most common soft tissue mass, often seen on the lung window. If you can identify, it is not there on the mediastinal window, the soft tissue window, and it is over here. It is within the airway, around the trachea. It's low attenuation, non-enhancing, and may even contain these air bubbles. So these are characteristic of mucus plugs. Sometimes when necessary, you can make the patient cough and retake the scan if it's possible, and this might disappear, completely disappear once the secretions are cleared off. Now, foreign body, as you can see on this chest X-ray, there's a presence of foreign body. Then again, foreign body aspiration. So this is a radio opaque foreign body in the bronchus, and there is actually hyperlucent lung because of the obstruction of the bronchus. There is air trapping. So this was because of the aspirate foreign body aspiration. Then again, this was a case of hydropneumothorax, and after putting an ICT, it was not expanding. So then this contrast, what you can see, so case of trauma, and there is a bronchial injury. There is air leak happening, if you can appreciate over here. Now, tracheobronchiomalacia is basically weakness of the wall of the trachea and the supporting cartilage. So what happens is that in this is an inspiratory film and this is an expiratory film, which is what you need both to identify. Now, in an inspiratory film, the trachea may appear normal or a little, the lumen might be a little altered like this. But when there is an expiration, there's almost complete collapse of the trachea because of the weakness of the supporting cartilage, right? You can see a crescent only. This is basically it's collapsing anteriorly. So this is a tracheobronchomalacia. That's how it appears. Then tracheobronchomegaly is another condition. You can see irregularly dilated, large, irregular walls of the trachea and of the right main bronchus. These patients are prone more to infection, and this can be an iatrogenic condition. It can result in recurrent infections because of too much of secretions. So tracheobronchomegaly is another condition. Then, after the airways, we've talked about infective, inflammatory, we've talked about congenital causes of central airway obstruction, we've talked about the masses, we've talked about miscellaneous conditions. Now, let's look at another type, which is bronchiectasis, which we often see, which is the irreversible dilatation of the cartilage containing airways and bronchi. Right? So, we've seen that we know that it is cylindrical, varicose, and cystic type. And I'll just show you bronchiectasis. So, you can see that there is, tram track like bronchiectasis and signet ring. What is signet ring? Signet ring is basically normally the artery and the bronchi are of the same size, right? But when the bronchi get dilated and the walls get thickened, so they are a little bigger than the artery. So it gives you a characteristic signet ring. So this is commonly seen in cylindrical bronchiectasis. Then varicose type of bronchiectasis, cystic bronchiectasis with grape-like appearance. So again, tram track-like bronchiectasis, signet ring, and then grape-like bronchiectasis, which are characteristic signs which we see for bronchiectasis in the patients. Now, imaging patterns in large airways, we see nodules within the lumen or along the walls of the airways, wall thickening or of the airways without stenosis, and also dilatation of the airways. Remember, the large airway diseases are a group of disorders centered on large conducting airways with non-specific clinical signs and symptoms. CT is the most sensitive modality for diagnosis, and the imaging findings include intraluminal nodule, wall thickening, stenosis, or dilatation of the bronchi. And the findings help you to localize and characterize the disease with formulation of differential diagnosis, but they're not specific. And the final diagnosis may require biopsy in certain conditions. Now let's look at the imaging of the small airways. Now small airways are basically which measure less than or equal to 2 mm in internal diameter. They are membranous and respiratory bronchioles, and they lack cartilage or submucosal glands. Pathological conditions involving the bronchi primarily or as components of interstitial or alveolar disease. Normally, these don't contribute, only contribute about 10 to 20% to the airway resistance, right? But when they're diseased, they contribute disproportionately. And they're usually either not detected or detected very late on the PFT. Now, chest X-ray gives you non-specific findings. HRCT is the key modality for detection and classification of small airway diseases. We do single breath hold volumetric scans, thin sections. Remember, for small airway disease, you require an inspiratory and expiratory scan both. We look at the basic axial sections to begin with. After looking at the coronal sagittal reconstructions, we've talked about the maximum intensity projection for nodules and the minimum intensity projection for air trapping. We'll talk about this as we go ahead. Now look at this film. Look at these CT films. You can see that this is an inspiratory film and an expiratory film. So during expiration, the volume is reduced. This white areas that appear, this is actually your areas of normal lung, and you can see areas of air trapping within. These can also be seen on the inspiratory film, but for air trapping, you require the expiratory film. Again, another expiratory CT scan. This is the one for air trapping. These areas are normal. These are your normal lung areas, right? And this is where the air trapping has become prominent. And this is an expiratory film. Now we talked about maximum intensity projection for imaging of nodules. Why this is important is that in certain patients, some patients, not always, you'll not be able to differentiate between the vessels and the nodules. So look at these four axial images. When maximum intensity projection image reconstruction is done, the vessels basically they get straightened and the nodules remain as it is, right? As you can see on this CT, they become straightened out, the vessels, and the nodules can be clearly seen. So maximum intensity projection is the image reconstruction that we do for imaging of nodules in cases where we cannot identify or differentiate them from vessels. Then we've already talked about the minimum intensity projection for the airway anatomy. Now look at these areas of air trapping, which are characteristically visible on your minimum intensity projection imaging. Now, small airway diseases are not directly seen on the CT, right? You have direct signs, which are the centrilobular nodules and train bud opacities, and indirect signs, which is mosaic attenuation and air trapping. Bronchular dilatation and wall thickening are seen in more advanced cases. Now, what are centrilobular nodules? Basically, centrilobular nodules are when your exudates get accumulated within the center of the secondary lobule, and they give you these nodules, nodular shadows. These are solid nodules, these are ground glass nodules, and they give you central tree in bud opacities, which are basically tiny clustered nodules with linear branching opacities adjacent to the vascular structures. So these are your tree in bud opacities and your nodules. This is just a schematic presentation of the direct signs. Then indirect signs, again, when you look at the secondary lobule, you see areas there's air trapping seen here, and these are the normal areas. This is how it appears on your CT scan. So this is just a schematic presentation, and you can see that interspersed between normal areas, there are areas of air trapping, giving you that mosaic attenuation pattern. So this is the indirect signs of small airway disease. Now, classification of bronchiolitis is cellular, which is basically inflammatory, and constrictive, which is bronchiolar narrowing by fibrosis or scarring. Now, cellular bronchiolitis can be infectious, aspiration, respiratory, RBILD, follicular, hypersensitivity, and diffuse panbronchiolitis. Now, in the infectious, the causes can be bacterial, viral, fungal, including TB and, of course, NTM. Inflammatory cells, mainly neutrophils in the walls of airways and inflammatory exudates in their lumen. What would you see? Centrilobular nodules, tree in bud opacities. If you can see here, there are multiple nodules across the lung fields, micronodules, and then there are tree in bud opacities seen on both the sides. So this is characteristic of infectious bronchiolitis. This was a case of tuberculosis. You can see there's a thick wall cavitation. There's some tree in bud opacities. There's a consolidation over here. Again, thick wall, cavitation with surrounding consolidation, tree in bud opacity. So this was a case of tuberculosis. Now, tree in bud opacities, like I said, there are tiny clustered centrilobular nodules with linear branching opacities adjacent to vascular structures. Various causes of tree in bud, we all know infectious and non-infectious. Then again, this is a CT showing you the tree in bud opacities. Another presentation. Now, aspiration bronchiolitis is a chronic bronchial inflammation as a result of recurrent aspiration of foreign material. Now, this kind of bronchiolitis you would see in elderly who are bedridden, who have neurological disorders, who have problems of dysphagia, and you would find chronic neural inflammation on the of the bronchioles with foreign body reaction. So, what you would see centrilobular nodules, you would see tree in bud opacities, areas of consolidation, independent portions, as you can see over here in the lower lobe. So aspirant precision bronchiolitis is specific. Now, respiratory bronchiolitis patient would often have a history of smoking. And histopathologically, there will be submucosal inflammation and fibrosis of respiratory bronchioles and pigmented macrophages in their lumen. So there would be poorly defined centrilobular nodules with patchy ground glass, as you can see here. Something characteristic about respiratory bronchiolitis, if the patient stops smoking, this disappears. So that is something very characteristic of respiratory bronchiolitis. You can see there's a very dirty lung kind of a presentation. Now, follicular bronchiolitis is something which, with the characteristic history, is diagnosed on histopathology, wherein there is peribronchial and peribronchial lymphoid follicles. And conditions like collagen vascular diseases, immunodeficiency syndromes, lymphoproliferative disorders, systemic hypersensitivity reaction, bone marrow transplantation are the associated conditions wherein you would see follicular bronchiolitis. As you can see here, there is ground glassing with ill-defined nodules. So, but this is generally diagnosed on histopathology, remember, and there is characteristic history for follicular bronchiolitis. Now, hypersensitive pneumonitis, we have a great lecture today on this in the today's session. It's an allergic lung disease caused by inhalation of organic and inorganic agents. And on histopathology, would have alveolitis and inflammatory granulomatous bronchiolitis. Now, in something characteristic about hypersensitive pneumonitis is a three cheese sign that they say that there is presence of ground glassing, air trapping because of involvement in the small airway and the normal lung. So you would see diffuse ground glassing. You would see nodules. You would also see some areas of air trapping as shown on this CT film. But this is one of the characteristic presentations of hypersensitive pneumonitis. I will not go into details because we are going to be talking about this today. Then there is something known as constrictive bronchiolitis, which is post-infective. Sequelae, collagen vascular diseases seen in post-transplant, inhalation lung injury, and can be idiopathic. Now, in histopath, you would see collagen deposition extrinsic to airway lumen with peribronchial fibrotic scarring. And on the imaging, you would see mosaic attenuation of the lung parenchyma. So let's look at these images of constrictive bronchiolitis. As you can see, there are areas of air trapping interspersed between these. So these are characteristic of constrictive bronchiolitis. Again, this is an inspiratory film and this is an expiratory film. Now there is air trapping over here and there are interspersed these high density areas, these whitish areas that appear are also seen on the expiratory film. These are normal lung areas. So this, when it is seen, it is because of air trapping, and this is seen in constrictive bronchiolitis, which is also called the mosaic attenuation pattern. So mosaic attenuation is attenuation areas of increased and decreased lung attenuation, and it is seen in small airway diseases, lung parenchymal diseases, and occlusive vascular diseases like chronic thromboembolic pulmonary hypertension. Difference between small airway and occlusive vascular diseases you do in expiratory film. So you would see that on a small airway disease, but in occlusive vascular disease, there will be nothing seen on the expiratory film. Now, Swyer-James syndrome or McLeod syndrome is basically predominant involvement of one lung with constrictive bronchiolitis. It generally occurs because of the recurrent childhood viral infection. What happens is that there is restricted development of the lung and the pulmonary vasculature, and as a result, because of these repeated childhood infections, but the hyperinflation is maintained because of the collateral air drafts. So one of the lungs would appear hyperlucent, as you can see on this chest X-ray. Also seen on these CT cuts, you can see that there is hyperlucency. There is some areas of bronchiectasis as well. There's some areas of fibrosis as well. So Swyer-James is also a variant in which you see constrictive bronchiolitis. So, again, small airway diseases are also a group of inflammatory and fibrosing disorders. They are often, of course, restricted to the small airways, generally not detected on PFT, or very detected very late on PFT. They are not directly visualized. We've already talked about the direct and the indirect signs. Imaging findings help to serve the diagnosis, but they are not specific. And of course, you require a clinical and pathological correlation for diagnosing small airway diseases. Thank you.